Hello and welcome to my live stream. This is a special on blood pressure tablets today, at both high blood pressure and low blood pressure. I'm going to cover both ends and what is a normal range. So I would say welcome to everybody. There's already a few people online. Neil Peter's already put quite a few questions in the chat, which I will be going through. And hello, Mr. Ranger Lab as well. So I'm like, yep, you've just added a couple of questions in as well. So I will go through those. But I'll also talk about what normal blood pressure is, when to be worried, what the different types of blood pressure medications there are, whether there are any side effects, any long-term problems, how to decide which one is best for a particular person. And yeah, I'll just go with the flow and answer all of your questions. Hi Tanya, welcome to the live stream as well. So to start with, I will just do my disclaimers. So as usual, this live stream is for educational and entertainment purposes only, not personal healthcare advice, which you should be getting from your healthcare provider, but hopefully I should provide you with some information so that you can have a more informed discussion with your doctor and nurse about your blood pressure. And also bear in mind that I will be talking about the medications that are mainly available here in the UK. There are differences across the world with which brands are available. And then I'll just do my intro. Yeah, if you could like the stream, then it will help the YouTube algorithm share my videos more publicly across the platform, which I am still trying to increase my hours, YouTube watch hours. That's where I'm struggling at. I'm getting there with the subscribers. So I think so. Yeah. So everybody's saying hello to each other in the chat. It's always a nice chat here. Luckily, I've never had to actually get rid of any bots or trolls in this chat. There was so a couple of weeks ago, I did do a live stream on Ray's channel. She's a nurse in the US called Life in Vibe, and I was on her live stream, which I did stream to my channel as well. It went really well, but yes, there was a couple of trolls on there that had to get banned, but we always come across them and we just have to carry on. So, right, so blood pressure. Everybody's got one. Just saying sort of treating blood pressure. Well, if you didn't have a blood pressure, you wouldn't have any blood going around. So there's two figures to your blood pressure, a top number and a bottom number. And to sort of provide value of what that is, the bottom figure is the pressure that is in the system all the time. So that's just the general pressure. So if you were to sort of cut an artery, that's just the pressure pushing out that amount of pressure on the actual system. So like in any plumbing system, there will be a certain amount of pressure of that volume of water within the system. Now, the top button is the pressure as you do your main heartbeat. So the main heartbeat out of ventricles pushing into your body. And that's the pressure of that force. And that's the top figure. So the difference between those two numbers is the difference between the stating force and the push of each heartbeat. So both are important because the bottom number, if that's continually high, that's continually putting a pressure on all your organs and all your systems. And then the top figure, as it pulses, that's the extra punch every time there's a heartbeat. As Scott said, now Peter asked, can your blood pressure be too low? Yes, it can. Your blood pressure going too low is quite often what happens when somebody goes into shock. the blood pressure drops, the heart's not being able to pump as efficiently, and it drops down. And actually, your blood pressure dropping is more of a medical emergency, because if you drop to a certain amount, you're not going to get the blood flow, the oxygen, and the glucose to your brain and to your organs, and your body could start shutting down. So having a too lower blood pressure can be a medical emergency. Too higher blood pressure, to get to it being a medical emergency, that's when you're getting figures that are into, so the top figure's over 200. If ever you get a top figure over 200, it's worth just doing a double check, checking the machine works. But over 200 is a straight to A&E medical emergency. So that's the two extremes. The normal, you wanting to have your bottom figure in the range of somewhere between, about 65, 75, 80. And then the top figure, you're wanting it anywhere between about 100 and 130. Everybody's blood pressure will range during the day. As you're getting up and about and doing things, you will have a higher blood pressure than if you're just laying at rest overnight, asleep. Which is why sometimes if you've done blood pressure readings and they're either high or low, your GP may actually ask for different blood pressure measurements at different times of the day, including a 24-hour blood pressure monitor, to see actually when you are fully relaxed while you're asleep, what is your blood pressure doing? And when you're up doing activities, is there a difference? Also, it can be useful to do the difference between a sitting blood pressure, standing blood pressure, and a laying down blood pressure, to see if there's differences. There is also another condition where it's worth doing the difference between the two arms, because the main artery, I don't know which way around this is going to show on YouTube, the main artery from your heart goes down your left arm. So your blood pressure quite often in your left arm is slightly higher than in your right arm. So it can sometimes be good to do both. And if there's a significant difference between those two, then that can alert for different things to look out for. I just to say, now Keith says, I'm checking my blood pressure as we speak. Yeah, so when you're checking your blood pressure, it's good to try and be as relaxed as possible, not after just, like I've just been to the gym earlier, you wouldn't do it just after you've done some exercise, because it will be raised. You need to be nice and relaxed, nice and sitting. Yeah, maybe just generally talking. And then if it is high, rest for sort of 5-10 minutes, do it again. There is the type of high blood pressure called white coat hypertension, which is when people get themselves worked up and stressed about being in the doctor's surgery, and it quite often is higher in the doctor's surgery. And so getting at-home monitors at home can be very useful. In the UK, we now do have community pharmacists can do blood pressure monitoring, which can be a more sort of, well, it could be a more relaxed environment, but quite often when people are running around getting to the pharmacy, they could also have been a bit more stressed getting there. Yeah. So yeah, fainting from low blood pressure. Yeah. So if somebody ends up with a low blood pressure because they're dehydrated, been doing too much activity, then yeah, you can end up fainting. Right, I think. Hi, Lisa. Nice to see you as well. Yeah, so there are the wrist blood pressure monitors. Sometimes they're not quite as accurate, so it can be worth occasionally calibrating them and checking the results. One way you can do that is when you next go for your actual blood pressure monitoring at the doctors, is take it along with you and see if there's a big difference between the two numbers. There shouldn't be, but it can be useful to just double check that. And if ever you have got a reading that's out of range, it is worth getting that checked. Another thing that's worth knowing is on um, any of the automatic blood pressure monitors, which is not actually the doctor actually listening to it while the stethoscope going, but actually it manually checks it. If ever it says that it cannot read your blood pressure, it's worth going and getting that checked because that could show that you've got something wrong with the rhythm of your heart. Oh, right. So, Mr. Ranger says, I have my GP office trained. They take it when I come into the exam room, always high, then take it near the end of the visit, always lower. Yeah, it quite often is. Now, Keith says, check twice to be sure. I'm around 112/69. That is pretty perfect. Yeah, so Tanya's saying her mum has had white coat syndrome. Yeah. I'll just say, Tanya said, between my mum having beyond low blood pressure and my dad needing blood pressure meds to lower his, I bought a home BP. Yeah, because you could end up going either way with the genetics that you've been given. Cal, you said you've had a low blood pressure of 10/6. I hope you were in a hospital when that happened, because that is very, very low. Going down, keeping an eye on any questions. Hello to my mum and dad. Yeah, no, I'm not quite sure. There must be, if that's like 100/60, they might have just taken off the thing, which 100/60, which is on slightly on the low side, but not concerning. Yeah. Would low blood pressure be a reason for it to be difficult to draw blood? Yes, it definitely could be. That's your body's holding on to its blood and keeping it more internal. So, okay, so 1 to 2 numbers for the pressures. Yeah, unless they're using a different pressure scale to the usual one, and then I wouldn't be able to say what's a normal range. So I'll just go back and do a stroke. So the target ranges for blood pressure depend on the person. So they are different target levels. It's usually to make sure that you're below 140, the top figure, and below 85 for the bottom figure. If somebody's got diabetes, then they do actually like those figures to be even lower, because having high blood pressure on top of diabetes really has an additive effect of putting you at risk of having heart attacks and having strokes. And so they like numbers to be even tighter, so that's usually 135/85 for diabetics. Once people get over 80-year-old, then they're not quite as strict at the keeping to those figures, because the risk of actually having the blood pressure drop and having low blood pressure is and fainting and falling is much more of a risk factor than the long-term risk of high blood pressure. So, look, I ought to actually go back to the beginning of why is high blood pressure a problem? As I was saying at the beginning, the high blood pressure means there's a high pressure of the blood going into your organs in your brain. And this can be particularly problematic in causing issues with strokes. So a really high blood pressure can trigger a stroke, and a really high blood pressure can also trigger problems with the blood flow to the heart and cause heart attacks and such like. And it can also cause some damage on other organs towards your kidneys, because your kidneys have got a lot of very, very fine blood vessels, which it uses for filtering the blood. But if there's too much pressure on there, it can cause kidney damage. So there's lots of reasons for keeping the blood pressure in range. It is basically a silent problem. For the majority of people, there is no way of knowing what your blood pressure is. Although some people may get dizzy with a low blood pressure, may feel faint with a low blood pressure, and very occasionally people with high blood pressure can get a headache. It's not always evident. Some people can be walking around with ridiculously high blood pressure and not have any signs and symptoms. And other people that can get a headache, but headaches can be caused by so many different things. So to actually put it down to being blood pressure is, well, it's just one thing that you rule out when you've got a headache. So, hi, Ray. I was just telling everybody about our live stream that we did 2 weeks ago and recommending your channel. I really ought to put you into my Nightbot so I can put it in. But if you search Life in Vibe on YouTube, you'll be able to find a channel. Yeah, so Carol asked, are there any issues with people having long-term constant low blood pressure? Yes, people with constant low blood pressure can have signs of things with chronic fatigue, unable to have a very low tolerance for doing any exercise, and can really cause massive problems. One of the things I will talk about towards the end when we go to low blood pressure is people with postural orthostatic tachycardia syndrome, which can be related to people that have had post-COVID and end up with POTS. A lot of teenage girls end up getting POTS as they go through the hormone changes. I've had POTS because it is related to Ehlers-Danlos syndrome, so it is something that I've done a lot of research on. But yes, there are problems with constant low blood pressure too, and there are things to do to get that. Yeah, so Tanya says when she has long migraines, she double checks the BP just to rule it out, and that can be very sensible, especially seen as certain types of migraine can actually put you at slightly higher risk of stroke and such like. And if ever your migraine is ever more severe than you're used to, or not responding to the medication like it should, then it can be worth getting checked out by emergency care or such like, just to see whether it is a normal migraine or it's something different. It can be very good. I would recommend if you have anything where your blood pressure is high or is low, it's always useful to have a meter at home. After you've been to your GP and had the meter reading done there, ask them what the result was, do it at home. You'll be able to then write down the same result from the same day and know what the difference is for you when you're either stressed in the GP and then relaxed at home, have that difference noted down. And then you can take your own readings, and some GP practices even allow you to sort of text your blood pressure readings through for them to put on record, to just keep an eye on it like that. Can be very useful if ever you have new medication started. You can then take your blood pressure every couple of weeks after starting the new medication to see whether it is working. Okay, so now Peter says, I think that's how we learned of my mum's blood pressure. Luckily, she worked right across from a university hospital. Yeah. So if ever you get a reading that's way too low or way too high, so, and Tanya says, I have gone to the ER for migraines and I ended up on you did? I don't recognise that brand name. And yeah, and it's so severe. You remember recommended earplugs and dark, yeah, dark sunglasses, I'm assuming that is. Yeah. Yeah, so things that can increase your blood pressure. So Tanya says that her blood pressure was elevated when she was in pain. Yes, being in pain can increase your blood pressure. However, also being in pain can send you into shock and lower your blood pressure. So you can go either way in in an accident or an emergency situation. Okay, so it said it was an IV opioid. Yeah. Um, so, and then people, after they've had operations, after anesthesia, you can end up with low blood pressure. So there's so many factors that can increase your blood pressure. When you do exercise, your blood pressure increases. However, over the long term, the more that you do exercise on a regular basis, helps your heart health and your blood vessel health, and will help moderate your blood pressure, so that continued regular exercise will actually lower down high blood pressure. But if you do have high blood pressure when you want to start doing exercise, you do need to start it off very slowly, keeping an eye on it, and not stressing too much. So it's a balancing act. One of the biggest things that can affect blood pressure is hydration. So that's why you'll probably hear of it always being said about salt. Now, the reason that salt is so important with blood pressure is that it's salt that holds water in your blood system. So, however much you hydrate with as much water as you want, your body will always keep the right balance of water, and your kidneys will filter it in and filter it out. However, if you drink a lot of water and very little salt, you will actually be flushing salt out your system, lowering your salt, and it will lower your water and lower your blood pressure. However, if you eat a lot of salt and you've got a lot of salt in your system, your kidneys will struggle to get all of that salt out quickly. It'll take time for it to get that salt out the system, especially if you've not got as much liquid coming in, and it will hold on to salt in your blood. Yeah, so salt is an electrolyte. So sodium, potassium, both sodium and potassium, they both work in a similar way, but it's mostly sodium in our diet. Having more salt in your diet holds more water in your blood system. So the more salt you keep in, the more water you keep into your circulation system in your blood, and it keeps your blood pressure up, which is why you'll always say it's recommended no more than 5 grams of salt in your diet a day if you've got high blood pressure, because then you're not putting that extra strain. However, if you have low blood pressure, it is worth having electrolytes and water in your diet, in your day, to keep up. So as Cal said, is using electrolytes in the water a good option for people with low blood pressure to help keep that balance? And that definitely is. So people who have struggle with low blood pressure, who have things like the postural orthostatic tachycardia syndrome and struggle with those drops in blood pressure, making sure that you have the correct amount of electrolytes with your fluid can be very helpful. You don't necessarily have to buy any expensive electrolyte drinks. You can just have salt in your diet, whether that be I've got a consultant and he recommends McDonald's chips, but any sort of crisps with salt on, adding a bit of extra salt on your food, and keeping the fluid intake up as well. So it doesn't necessarily have to be by expensive electrolyte drinks, just by ensuring that you've got plenty of water and plenty of salt. So hopefully I've got that right, that it's a balance. So blood pressure is increasing, reduce the salt in your diet. If your blood pressure is too low, increase the salt in your diet. So Tanya says, I've been told by my PCP to eat more salt. I don't like salty food because my sodium levels were low. Yeah. So there is certain conditions where your sodium levels can get low. This can be, this is when you hear of people that have overdosed on water. You can actually drink that much water that your body's trying to flush the water out your system, and it has to take out a certain amount of electrolytes with it, and you can end up with low sodium. There are also some medications that can cause low sodium levels as well. So anybody who's got persistently low sodium would need sort of a review of their medication to see if there's anything that's causing that. So Tanya says, my dad had a stroke, so I actually got out of practice with adding extra salt, and it's actually made you deficient. Yeah, that's it. Anything, it's finding the balance. So yes, some people may need a very low salt diet. Some people may need a very high salt diet. So it can go either way. So Jolene says, I've skipped to the live, so apologise if I shouldn't have. How does BP affect vision? Very occasionally, either extremes of blood pressure can affect vision, mainly because of putting pressure on the back of the eye, but it doesn't necessarily have to. Some people can have extremely high blood pressure and it never affects the vision. But I would always say, if ever you have any problems with your vision, the first person to go to is always an optician. They are the experts in eyes, and if it's beyond their scope, they will refer you directly into an ophthalmologist with cutting out your GP. But I would always go to an optician. They can look in the back of your eye. They can see the health of the blood vessels at the back of your eye and check. Now, there is also the other thing which affects vision. There is what's known as, well, glaucoma, which is ocular hypertension. And that's not to be confused with blood pressure hypertension, but it's actually the ocular pressure, and it's the pressure of the fluid in your eye can get too much, and that's what causes glaucoma. And it's separate. It is just the pressure inside the eyeball, and it can obviously cause problems with your vision because it's bulging the eyeball into the wrong shape. I am sure that Mr. Angelab would be able to go into that, but I would say anytime that you've got anything vision related, go to your optician first, get them to actually look in your eye, because they can they can really get to the root of the problem. So Cal says, something I eat to add salt to my diet is salted tomatoes. It's nice and adds veggies and fruit. Yeah, tomato technically is a fruit, but there again, what I learned out the other day, that a banana is a berry, but a strawberry isn't, and I got totally confused. So yeah, there is the technical scientific way of naming things, and then what we've always got used to. So salt substitutes, there is such a thing that's called low salt, which is actually, instead of it being sodium, is potassium. Potassium is still a salt. It is still something that will help in your keep your fluid in your blood pressure, but it is complicated with potassium, because your potassium levels can get very fickle, especially if you're on medication for blood pressure, because some of the medication for blood pressure can lower your potassium and some can increase your potassium. So I would always run that by your doctor or pharmacist to check whether you're safe to have potassium. Because if you're on something like an ACE inhibitor, then I would not recommend swapping over to a potassium salt substitute, because you're actually at higher risk of getting high potassium levels. Yeah, so Carl, you're right. Peanuts aren't nuts. They're its own thing. Jolene said, I had the ophthalmologist tell me I didn't need to replace my glasses because I didn't have any reason to see clearly anyway. And then he spiked my tear duct. Okay. doesn't really make any sense to me, but I'm not that much about eyes. Now Peter says, eyes are so complicated. Mom and now I get optical migraines. Since she has high blood pressure and I have low, we've crossed that off as the reason. Yeah, optical migraines. Yeah, migraines themselves have a different pathway of how they're caused. They are caused by changes in the blood vessel lining, but it's not related to actually the blood pressure within there. It's to do with the actual lining of the blood vessels. Okay, yeah. I would say, yeah, Joe, take Mr. Angelab's advice and get a new ophthalmologist. Yeah. Right. So I'll go back. So I think I've covered sort of things. So the things that you can do to help keep your blood pressure in check is have a healthy diet. Obviously, reduce down processed food. Have as much sort of things. Increasing your fibre is very good. It helps. And then reducing alcohol. Alcohol's a funny one. In the long term, it can increase your blood pressure. So if you're continually drinking alcohol, it can increase your blood pressure. Obviously, when you're drinking alcohol, it can be all over the place, especially if you can get dehydrated from the drinking of alcohol. With a hangover, you can end up with low blood pressure. But yeah, moderate alcohol. Smoking can actually increase your blood pressure because of the way that it constricts blood vessels. The same with caffeine. Caffeine can increase your blood pressure because it can increase your heart rate and acts as a stimulant on your body, increasing your blood circulation and pressure. So reducing caffeine if you've got high blood pressure. Okay, Tanya says, Sean, my son has to see the paediatric ophthalmologist that specialised in diabetic care, and they're so hard to find. Yeah, they probably are to be niche. You can find a paediatrician, you can find ophthalmologists, but finding one that actually has that crossover. But yes, people with diabetes, both the high sugar can cause damage to the small capillaries and blood vessels, and the high blood pressure can cause damage to the tiny capillaries and blood vessels in the backs of your eyes, which is why every year they should have an eye check in the kidneys. So the kidneys should be checked every year. And yeah, and then also at the extremities in the hands and feet. So Jolene says propranolol long-term effects. Right, yeah. So I'm going to go through all the different groups of medication for treating. So there's four main categories of medication for treating blood pressure. There's the renin-angiotensin system ones, which is the ACE inhibitors that all end in pril and the sartans. They are basically very similar. They're just different with their side effects. Then there is beta blockers, which can also be used for many different other conditions as well. Then there's calcium channel blockers, such as the amlodipine, but also verapamil and diltiazem. And then there is diuretics, but usually when we're talking for diuretics for blood pressure, it's usually bendroflumethiazide. I know in America it's something else that ends in flumethiazide. I think it's chloroflumethiazide or indapamide. And yeah, so I've done it. So beta blockers, ACE inhibitors, calcium channel blockers, and diuretics. There is also alpha blockers that can lower your blood pressure, but we don't actually use them as treatments for lowering blood pressure unless you get to needing a fifth line agent. So, okay, so yeah, Tanya says type 1s are predisposed to glaucoma. Yeah, so you probably need to start glaucoma testing much earlier than the 40 years. Oh, Hi, Angel of Glass. Great to have you here. Yeah, so Tanya says her dad's on lisinopril, but that it made her throat itchy. So yeah, so we'll start off with ACE inhibitors. Now, ACE inhibitors, the first one was captopril, and the way that the captopril was actually discovered was by some snakes in the Amazon. They found that when these snakes in the Amazon bit people and gave them their venom, the person's blood pressure would totally bottom out, send them into shock, and that's how the venom could kill people. So they extracted the venom, found out the molecule in it that caused that massive drop in blood pressure, extracted it, and made a synthetic version of it, which was captopril. And then every single other drug company created a sister drug to that. They all compared each other. They tried to get sister drugs that would last longer in the body, have better actions, and that's why we ended up with a whole range. I think there's about sort of 10 or 12 different prills on the market. But the main ones that have come out as having the best evidence is lisinopril, enalapril, and ramipril. They tend to be the three that are mostly used, mainly because they can be used once daily, although sometimes twice daily. Because captopril, although it can be very good at getting the blood pressure down very quickly, you need to take it 3 times a day, which is not very patient friendly and something that you've got to actually take long term for the rest of your life. That is the other thing, is that it's usually very unlikely, once you've actually been diagnosed with hypertension to the point of being medicated, that you'll become unmedicated. Very occasionally, if say you were extremely unhealthy, extremely obese, extremely sedentary, and really managed to turn your life around, you might be able to get off the blood pressure tablets. But usually, most people who have high blood pressure, it's genetic. You've got it, and you're probably going to need medication. Yeah, yeah. Cal says it always amazes me how much medication is actually made from poisons, and that always is the thing. It's the dose that makes the poison. So anything that has an effect on the body, you can actually work out at what point is that effect beneficial, to what time, at what point is that action not beneficial. So obviously, it's not beneficial to have your blood pressure drop, but if you've got high blood pressure, having something that lowers it does work. So it's fetching you back to the midpoint. Hi, Julie. Yeah, you're not that well. You're not that late. I've not really got that much onto the medication yet, so I'm only just starting on the ACE inhibitors. So I started with the ACE inhibitors because the ACE inhibitors quite often are used first line for the majority of people with hypertension, especially for younger people when they're diagnosed with hypertension, and for people with diabetes. Now, that is because the way that it works is it opens up and makes the sort of, I want to say, can't think of another word for it, but makes the outside of the capillaries slightly wider, but sort of more consistent. So say increases the patency of the blood vessels. So it makes the blood vessels sort of a bit more hardy, but allow more blood flow going through them. And they can be very good to increase the blood flow going to the heart. It increases the blood flow going into the kidneys, and it allows that pressure to sort of be released around the body more. And because it increases the blood flow to the kidneys, it actually can help prevent kidney failure. And so the long-term use of ACE inhibitors in people with diabetes is extremely useful, because it really does lower the risk of kidney damage later on. However, saying that, when you do start an ACE inhibitor, you do need to monitor your kidney function, because as it opens up the blood vessels into your kidneys and in the long term, that's going to be beneficial for your kidneys. If there is any underlying issue there, it can trigger a quick downward spiral. So quite often you'll need to have blood tests just to check your kidney function as you start ACE inhibitors, to just check that nothing goes wrong. But if you can get through those first few weeks of being on an ACE inhibitor, it then actually protects your kidneys long term. So it seems a bit sort of weird how you have to check the kidneys when you start on it, but in the long term, it actually really helps kidney function and helps maintain kidney function, especially from any damage from diabetes. So the side effects. So when it comes to the side effects of blood pressure tablets, they all say dizziness, and that's because it does alter the way that the blood flow goes around your body. And although it lowers your blood flow, it can then sometimes cause a bit of a sort of difference in your blood flow around your body that your body needs to get used to doing. So it can cause sort of a lower amount of blood going to your head, causing lightheadedness and dizziness. And I did have that question back at the beginning about sort of can lightheadedness be related to BP? And yes, it can be. Having a low blood pressure can cause lightheadedness, but you can also have lightheadedness with a normal BP, but it does seem to be in an upright position. Your body's not quite put the right amount of fluid to your head, and it may be more of the fluid is to the bottom of your body, which can happen with a few of the other medication. So, oh yeah, I'm just everybody's saying hello to each other. That's nice of you all in the chat. So, if the other main side effect that can happen in about 10% of people on an ACE inhibitor is having a dry cough. Now, this is a cough that sounds totally different to if you've got a chest infection. It's sort of at the base, at the back, and it's just a really dry cough. And it's to do with actually the ACE receptors in your lungs that it's affecting, causing that cough. And if that is the problem and that is the side effect that you're getting, you can swap from a ACE inhibitor to a sartan. So sartans, they've got candesartan, losartan, and these working the same way, but whereas the ACE inhibitor works on two pathways, the sartan only works on one of the pathways, which is not the side that causes the cough. So it's a bit more selective. And for a long time, they were always used as the second line because they were developed secondary to the ACE inhibitors. The ACE inhibitors that come off patent were extremely cheap. Sartans remained on patent for a lot longer. They were more expensive, and they didn't have the same long-term outcome data as the ACE inhibitors because they were still newer. So they were always reserved for second line. We've now got to the stage where they are off patent the same. They have dropped in price to similar. They have now still they've got the long-term studies to back them up that they work effectively long-term. They reduce the risk of stroke. They reduce the risk of heart failure. Oh yeah, that was the other thing I was going to say. So ACE inhibitors and sartans are both used in the treatment of heart failure to keep the heart pumping efficiently. So it's another way, because of the way that it opens up the blood vessels to the muscle of the heart, ACE inhibitors keep the muscle contracting very well. So it's protective on the heart, protective on the kidneys because of opening up the blood vessels. So ACE inhibitors, sartans, they're the first line for diabetes and for younger people. Now, if you've not got diabetes and you're older, or if you're African or Caribbean, then the first line agent is a calcium channel blocker. Calcium channel blockers are your amlodipine, licardipine, also your diazepams and your verapamils. And these work by relaxing your blood vessels so that they open up. And if you talk to anybody who's done any plumbing or engineering, or you know of anybody that sort of understands the plumbing of the system, if you open up and have bigger pipes, you can have a bigger flow going through them at a lower pressure. So to get the same amount of fluid going through a wider pipe, you don't need as much pressure. So opening up the pipe of the your blood vessels allows more blood flow at a lower pressure. So the calcium channel blockers work by that method. They also can work on what are called the calcium channels, which puts the electrolytes going from the inside of muscle cells to the outside of muscle cells in the blood flow. It keeps that balance right. So it can actually keep the heart muscle beating well. It can also help on the electric signals going around the heart. And this is particularly true for the diltiazem and the verapamil. And they can actually both be very useful for people who have certain types of arrhythmias, which is arrhythmia means just a heartbeat that's not the normal beat, it's slightly off. The electric signal going across the heart to say which parts. So the atrials should beat first, and then the ventricles, you should do a bump, bump, bump on your heart. If that's not going right, so and it's not fully in sync and the signals aren't going well, then verapamil and diltiazem can help treat that. Whereas the amlodipine and the leukotriene don't act as much on the heart, they actually act more out at the extremities of your body. So they're usually used first line if pure hypertension. The main side effect that comes with amlodipine is swelling of the ankles and legs. And that's because it opens up the blood vessels that are going down. And if you don't actually have the pumping going back up, if you've got a sluggish lymphatic system, or you're continually on your feet all day, your legs are down, you've got gravity as a disadvantage, your muscles in your calves aren't as strong, then you can actually get ankle swelling with amlodipine. And if that is a problem, you may need to be switched off the amlodipine onto an alternative or added in a diuretic. But yeah, quite a good percentage of people do have that with amlodipine. So although it's the cheapest, although it's the one that's got the most evidence long term, some people do need to be switched off that onto a different calcium channel blocker. Okay, I'm just going to go. We've got some interesting things in the chat. So Tanya says, like the guy who discovered penicillin, he saw the mold and thought, hey, let's see if we can do something beneficial. Yeah, there's so many things that serendipity, where they discover things by accident or they just try things. Jolene says, I take losartan now and propanolol, and would also be taking amlodipine if it wasn't out and unable to refill. Oh, I've not heard of any supply problems with amlodipine in the UK. That is really annoying because that's one of our major uses. Yeah, we have to, yeah. Oh, Tanya says, why these certain groups of people, though? Genetic predisposition. Yes. So they have done some breakdowns in some of the really big blood pressure trials. They did actually do some breakdowns of male versus female and of different ethnic minorities. And some of the trials were actually big enough to actually show that there were differences for what was best for the Black African and Caribbean, that they actually had better outcomes with the calcium channel blockers to the ACE inhibitors, and that diabetics had better outcomes with the ACE inhibitors. As for if you've got both type 1 diabetic and Black Caribbean, I don't know which one you would go for. But yeah, there really should be more studies. Most studies are done to show significance over placebo or significance over the other most used medication in that group. And they don't always do a big enough study to actually do breakdown. So it's not until medication has been on the market for decades, where we can do observational studies on a population basis of tens and, well, hundreds of thousands of patients and into millions of patients, that we can actually then start doing breakdowns to people of different genetic makeups. It is going to be one of the things going forward, is looking at genetics and ethnicities, and see if there is a difference in the way that people act to medication. It's an area that I'm quite interested in, but there isn't really much data out there yet. But it is really useful to know, especially there is some different liver enzymes in different genetics that can make a big difference on how long a medication stays in a person's body, or how long it actually takes to get active. Yeah, so Jolene says, oh, you just can't get a refill. Okay. But yeah, it can cause ankle swelling. So they're usually the first two, and you either start on one or the other. And then second line, you can start on the opposite one and add that in. And then the next thing that's usually added is a beta blocker, which is propranolol, atenolol, bisoprolol, anything ending in olol. There's a whole range of them, cardavidolol. Now, some of the different beta blockers, some act over the whole body, sort of systemically across the whole body, and some of them have developed to be acting more specifically just on the heart. So bisoprolol and carvedilol and atenolol act more centrally just on the heart, whereas propranolol acts system-wide. And that's why propranolol can also be used for many other things, such as treating migraines and essential tremor and anxiety. So beta blockers act by blocking the receptors that things like adrenaline and cortisol act on. So when you get stressed and you get your flight or fight system switched on, your sympathetic nervous system, as it's called. So your tiger's sat in front of you, your body produces cortisol to go, I'll either run away or I'll fight it. Personally, I'll probably just curl up in a ball somewhere. But that's your cortisol, and it sends it out, and that increases up your blood pressure. So the cortisol goes to receptors to increase your blood pressure, increase your heart rate, and so that you're ready. So there's more blood going to your muscles and organs, ready to go. Also takes blood away from your intestines. So having a beta blocker can be very useful in sort of switching that system off. So it lowers your heart rate, lowers your blood pressure, although not always. I'll explain that in a minute. But generally, it lowers your heart rate so that your heart can actually do nice, slow, steady movements rather than getting fully out of control. But it can also reduce anxiety, it can reduce migraines, and acts brilliantly across the whole system. Whereas things like the atenolol and bisoprolol only work on your heart, lowering your heart rate down. Now, when I say that, in the majority of times it lowers your blood pressure. So if you have high blood pressure and you lower down your heart rate will actually settle down, and you'll have lower blood pressure. You'll have a more normal blood pressure. Now, some people who have POTS, so the postural orthostatic tachycardia syndrome, so they stand up, the body releases the cortisol, the body tries to get blood going to the brain because the fluid falls away from gravity, and the heart starts beating way too fast. So the heart rate suddenly goes from being sort of resting at 70 or 80 to up at 120, 130. And because it's going too fast, it's very inefficient. So instead of doing nice, good pushes of that of blood around your body, it's doing that, and it's really not pushing the blood and the blood pressure drops. Now that's the case when where a beta blocker can actually raise blood pressure, because it's actually stabilizing the heartbeat and stopping it going too fluttery and allowing it to keep a sensible heart rate with a sensible push, and can actually keep the blood pressure sensible and stop it dropping too low. So in a way, sort of a beta blocker modifies the blood pressure. So if it's too high, it'll fetch you down, and if it's too low because your heart rate's gone funny with stress, with POTS or such like, it can fetch it back up. So yeah, so I'm on propranolol for 3 things: for my migraines, for my essential tremor, and for my postural tachycardia syndrome. And it actually, my blood pressure is higher on my beta blocker than it is off my beta blocker, because it keeps my heart rate sensible. So that's the beta blockers. Beta blockers. Now, a beta blocker is the opposite to a beta antagonist, which is what a salbutamol inhaler is. So the blue reliever inhaler, I think it's albuterol in the US. So people who have got asthma and people who have got COPD can struggle taking beta blockers. So they can trigger an asthma attack in somebody that is asthmatic, especially if it's a more of the broad spectrum sort of beta blocker of propranolol. Sometimes, depending on the type of asthma or the type of COPD, very occasionally, if they are pushed that a beta blocker is really needed, they can trial one of sort of like the carvedilol or the bisoprolol and start at a low dose and see whether it's okay without actually triggering any breathing problems. Well, that's the main reason why a beta blocker wouldn't be used, is in breathing problems, if it triggers breathing problems. Now, I did have the ask about the long-term for use of all of these. Now, for all of these, they have shown in all studies that all of them reduce the risk of heart attacks, strokes, and long-term mortality. And even when they checked for other things, they did think that there is a mechanism why calcium channel blockers might cause diabetes or trigger diabetes, because it does affect the pancreas cells and the increasing the way the pancreas cells work. So they thought it might actually trigger diabetes. But actually, they've all been shown to actually be preventative of diabetes problems long term. So although possibly you may have the diabetes trigger slightly early, in the long term, your actual overall health and mortality is going to be better from being on all of them. And as I said, like the ACE inhibitors are very protective of your kidneys from any damage from your diabetes. So long term, there is no long-term safety problems with any of them. You're going to get side effects such as cough or the leg swelling. They will happen early on or at an increasing dose. So if you actually need to have the dose increased, that's when you'll have them sort of within the first few weeks. But once you've been on them for sort of a good year going onwards, they're only going to be providing benefit. There isn't really any long-term problems that have appeared for any of these medications, which is great to know. As you may want to look back at my video on the proton pump inhibitors, which that didn't happen. Proton pump inhibitors got put on the market, brilliant, stopping all these gastric problems. They thought, well, actually, we're probably going to see a lot less deaths overall. But actually, when they looked at people taking long-term PPIs, there wasn't. There is subsets of problems with continuing proton pump inhibitors long-term, which is why we need to, even when drugs get a license and proven to be safe to get a license and proven to effective to get a license, we need to continue having observational studies long-term for decades after to see if any problems will turn up. So Jolene says, I have all 4 of those things: tremor, migraines, BP, anxiety. It does help with the first three, not so much the anxiety. Right, so propranolol doesn't treat anxiety, it treats the physiological effects of anxiety. So it doesn't fix the reason why you've got anxiety. So that would need to be by CBT or therapy or anti-anxiety medication. What it does is stops your body reacting to anxiety as bad. So it stops those palpitations and such like that you have when you have anxiety. So it stops the tremors and the tachycardia when you have anxiety, which you say it is treating your essential tremor and your blood pressure. So it does that. So it's stopping the physiological effects of anxiety, which obviously when you get them, then it makes you even more anxious because you're actually feeling it. Patricia says, can you go from having high blood pressure to having low blood pressure? Yes, you can. So during your life, you can go from one to the other, although usually it's the other way around, people going from having problems with low blood pressure to high. But then actually, then yes, as you're getting older, as you lose your muscle mass, as you lose the muscle mass of your body that pumps the blood around your body, as you lose blood volume, maybe because you're losing body weight, you lose the maybe losing muscle mass of your heart, everything's tiring out, then yes, you can then go from high blood pressure to low blood pressure, which is why when people are over 80, we don't not quite as tight to wanting to control the blood pressure because the blood pressure is likely to decline over those coming years after being 80. So need to sort of keep an eye on it. So yeah, so that's happened to your mum. So she's gone from having high blood pressure and then it's dropped. And so it can be useful to make sure that you have the yearly checkups. Sometimes when people are on multiple medication, it can go to having sort of these checkups every 6 months to keep an eye on it. And then if there is any other diagnoses and problems being added on top, especially one thing to look out for is the blood pressure goes from being high and drops to being low. It's good to sort of maybe have an echo and a check on the heart to see if there's any signs of heart failure, because if your heart's been under stress for years, your heart's starting to get tired. And that's basically what heart failure means, is your heart's getting tired. And they report it as a percentage of function compared to sort of a perfect heart. So people quite often can get freaked at the sign of heart failure, but it's just sort of the heart getting tired, and so obviously you'd start at 100%, and if it's getting down to less than 60%, that's when they usually diagnose it as sort of first stage heart failure. But first and second stage heart failure, there can be a lot done to sort of help maintain the heart function, and it's then when it's in stages 3 and 4 where there's real problems. Now, this might sound counterintuitive, but the blood, as I've sort of said before, the blood pressure can drop with heart failure, but the two best medications for, well, there's now 2 extra. The 2 best medications that have always been used for treating heart failure are an ACE inhibitor, because that keeps the blood flow to the heart muscle good, and a beta blocker, because that keeps the heart not trying to go too fast. It keeps it slower, and a slower heartbeat, so a better heartbeat. Okay, so COPD. So the COPD may mean that it should have to try whether a beta blocker would help. But sometimes, yes, if the lungs aren't functioning as much, the blood flow back from the lungs to the heart. But there's another type of blood pressure where it's the blood pressure on the system, instead of the system from your heart to your body and back, the system from your heart to your lungs and back. And that's known as pulmonary hypertension, which is a totally different sort of set of drugs for treating that. One of which is Viagra or sildenafil, that's used to treat pulmonary hypertension. But that's a different problem. I'm going off a tangent there. So the fourth line agent for blood pressure is the diuretic. As I said, that would be benzoflumethiazide, which I really hated it when they changed to the American saying of that. Because we used to call it I don't know if I can even say it, bendrothiazide, but now we call it benzoflumethiazide. So it works on the kidneys to try and kick out any excess potassium and water out of your body to reduce the amount of water in your blood system. So reduces the pressure by reducing out the water out of the system. So when it comes to taking diuretics, these are always best taken in the morning, because if you take them any later on in the day, they can disrupt sleep, because they will make you go to the toilet for the next 8 hours or so. And even if you are taking a diuretic, you should always still make sure that you stay hydrated, because you still need a certain amount of water each day for your kidneys to function. And if you will become dehydrated if it's kicking out the salt and the water and you're not keeping your fluid intake up. So you still need to keep your fluid intake up even if you're on a diuretic, unless you've been told, because you've got either heart failure or kidney failure by those specialists, to lower your fluid intake. But if you've got high blood pressure, you still should keep your water up. It's just whether you're keeping your salts down and on a diuretic. So I did mention about that there is some other diuretics. There is the loop diuretics, which is your furosemide, and then there is also spironolactone as well. Now, they all work slightly differently on the kidneys, and sometimes they can be used differently. But the spironolactone and the furosemide quite often are used more for patients with heart failure or patients who have, well, spironolactone is also used for treating acne, but that's totally weird side effect of it. Furosemide can be used for people who have got lymphedema, which is fluid in the legs that just doesn't pump back up. So it's swelling in the legs, and can be also swelling in the arms of fluid that's just not coming back up the system. So that's where furosemide can be used. I'm just keeping an eye on the thing. So Jolene's got a nasty storm and power is flicking. Okay, so yeah, so if you can always catch it on replay. So Patricia says, ever thought pharmacists learn a lot? Ever thought about becoming a nurse? No. No, everybody wanted me to be a doctor because I was doing great on all my A levels and everything, but I didn't want to be the person that was dealing with patients that were dying, having to deal with the relatives of people that had died and such like. So being a nurse also would have been off the table as well. I like doing the whole chemistry side of it, learning the actual drugs, the pharmacokinetics, all of that side of it. And I do get okay with dealing with patients, but for the majority of the time, I don't actually have to get too emotionally attached to my patients. Yeah. Okay, so you're in Oklahoma. Okay, so I can remember where that is on the map of the US. Yeah. So yeah. So the lymphedema with the swelling, so the fluid just stays there. They have to do a lot of wearing compression garments and such like to keep the blood flow going. The live stream that I did with Ray 2 weeks ago was on lipedema, which is different because it's fat deposits that are on the legs and sometimes the arms. But lymphedema is where it's fluid that's sort of trapped in the legs that your body struggles to get up and out. So, yeah, so I've covered most of the things to lower your blood pressure. If you that's 4 agents that I've done. So it would be either an ACE inhibitor, especially for diabetics, calcium channel blockers, especially if African Caribbean. Those 2 first and second line. Third line, your beta blockers, if you can tolerate it and you don't have asthma and COPD. Then a diuretic. And then after then, there is alternatives of adding in extra diuretics or of the different types, the spironolactone, adding in an alpha blocker, although an alpha blocker, that's doxazosin, although it does lower your blood pressure, it's never proven to actually help prevent any cardiovascular outcomes or preventing strokes or anything. So although technically, yes, it can lower blood pressure, there is actually long-term benefit in lowering your blood pressure with that, because it doesn't actually sort of extend your life. It just changes the figure, which it depends on what else is going on and whether that would be useful. Now, I'm just going to cover what time of the day to take blood pressure tablets and to when to actually measure your blood pressure. So most of the blood pressure tablets are either given daily or twice daily. So if they're given daily, that's because their mode of action is at least 24 hours. However, there will be an increase, and it'll be maximum benefit after in the range sort of 1 to 2 hours after taking. So once it's got into your stomach and got into your bloodstream and started acting, and then it will tail off to the 24-hour mark. But there should be enough left in the 24-hour mark that you can then take the next dose, and there isn't a massive jump between. If it's twice a daily, it'll be because it's not lasting for the 24 hours, so they're asking you to take it twice a day, which sometimes can happen with Ramipril. They like you to take that one twice a day. When it comes to the diuretic, as I've already said, the diuretic is best taken in the morning so that you can get that fluid off first thing in the morning. It will work your kidneys, and then you can be going to the toilet during the day. Now, I do know that a lot of people with the diuretics really struggle with taking it and then needing the toilet for the next couple of hours. And quite often, if they've got to go out for the day or such like, they will not take it that day. And that can obviously become problematic if there's quite a lot of days that they're going out and that's happening. So for those people, I would say you may be best off. That is what you happen to do when you do go out for the day. Take it once you get back in, as long as that's not going to be too close to bedtime. If you're going to get back in at lunchtime or you're going to get back in at tea time, take the diuretic then you can have a few hours before you're actually going to sleep to take the fluid off before you go to bed, especially if quite often if you're going out and about, you're probably going to be more on your feet or more upright, and so you're probably going to have more fluid retention anyway. Patricia's just said, can the lymph thing and the diabetes thing be tied together? I've not heard of anything that says that they're tied together. I wouldn't know without actually having a look. That would need some research. You could probably research if there's any thing, but they are both quite common things to happen. So there'll be quite a lot of people that will have both, but I don't think either one means that the other one is more common. Yeah. So some people do find that when they take them blood pressure tablets, it can make them feel dizzy. Now, this isn't always because it's dropped the blood pressure too much. It can just be because it's changing the way the blood pressure is, and just not as much is getting to the brain. Maybe it's opened up the blood vessels to the body, and there's more blood getting to the body than the head when they go from laying down to standing up. So this is what they call orthostatic hypotension, which is going quickly from laying down to standing up, causes the drop in blood pressure and the drop in blood going to the head. And so quite often for the majority of people, once you're on blood pressure tablets and they've lowered you to normal range, it's always best to get up slowly. So no jumping straight out of bed and running to the loo, because it can quite often cause problems with you fainting halfway to the bathroom. So people that do get that dizziness, if you do get up in the night to go to the toilet or getting up in the morning, sit up, sit on the edge of the bed, stay there, make sure that you've fully got your bearings, that your brain is sort of getting the right amount of blood flow, even doing sort of simple exercises of curling up the toes, clenching the calves, to sort of make sure that the blood flow is going before then standing up and slowly moving to the bathroom. So this is something to really watch out for with older people with on a lot of blood pressure tablets, this orthostatic hypotension on the quick standing up. If it is becoming a bit too much of a problem and it happens at a certain time of day, then sometimes changing when the blood pressure tablets are taken can help that. So sometimes if it's always happening sort of after they've taken the tablets in the morning, it may be worth swapping so that instead of all of them being taken in the morning, some are taken in the morning, some are taken in an evening, splitting that dose so there's a more even um, level during the day, or even asking the doctor for the half strength tablet and taking two of them, one in the morning and one at night. So I hope that makes sense with that. Obviously, I was going to say about sort of treating low blood pressure. So as I said, treating the low blood pressure can be used by having a beta blocker if that low blood pressure is because of the tachycardia and the heart rate going too fast. Other things to treat low blood pressure is increasing salt. And that actually can even be done by treating with salt tablets. And it can also be done by treating with medications that hold salt in the body, which is things like fludrocortisone, which is a steroid, which helps your body retain salt and then helps keep more salt in the body, keeps more fluid in the body, keeps that blood pressure up. And then also another medication called midodrine, but normally for treating long-term low blood pressure, usually comes under a specialist. But yeah, there are options for treating low blood pressure. And the treatments now coming out for the post-orthostatic tachycardia syndrome are getting more known. More GPs are knowing about it, seeing the signs, and actually referring people to cardiology to actually get treated for it, which has been a great change over the last 10 years. Cal says, yeah, I used to take low blood pressure meds, but they were no longer available in Belgium. My pharmacist had to import them from Germany, and that stopped being an option. There seems to be a shortage. There can be a shortage of it. There is midodrine. There was another one as well, but I can't remember it off the top of my head. But there was another one that they use as well. And yeah, I probably should have made sure I double checked it all. I can't remember it off the top of my head. There's only so much that I can hold in my head. I do still have to look things up. Yeah, so Ray says, yeah, I was about to write that I'm familiar with giving midodrine with diabetic patients. Yeah. So I think I've probably covered the majority of high blood pressure, low blood pressure. Yeah, trying to have a healthy guide. Oh yeah, the other one that I was going to say is, I think I said some of the blood pressure medications, especially the ACE inhibitors, can raise your potassium levels, and some of the diuretics can lower your potassium levels, and some of them can higher your potassium levels. So one thing that you will always need when you are on blood pressure tablets, as well as going to have your blood pressure checked every year, you will need to have your what's called the UNEs, so your urine and electrolytes tested to check that your potassium's in range and your sodium's in range, and then altered. Yeah, you may need to alter doses depending to keep them in range. Yeah, so electric MEMA, yeah. I do have quite a lot of information in my head. I'm always quite surprised at how much I do remember. I always think I don't actually know that much, but then when I suddenly start doing one of these live streams, and then I realise that, yeah, not everybody has this amount crammed in their head. But there's a lot of subjects I don't know. So I don't claim to be a specialist in anything else. Well, other than maybe Icelandic volcanoes. But yeah, I do very much need, I think that's one of the key things to being a professional is to know when your knowledge finishes and when to look things up. So I know very much how, if I'm not sure of the answer, I will always check it. I will always look it up, double check myself, talk to one of my colleagues. You know, sometimes we get questions and queries, and we're like, I'm pretty sure that this would be the best action, but I'm just going to double check with one of my colleagues on like if there's something that I haven't thought of. The also good thing to know is to know when you're doing a Google search. So yes, I can do a Google search and find the right answer very quickly, but I know which are reliable sites to go to, and I'm not sidetracked by sponsored sites, which is one thing I would always say. If you ever want to ask something to Google, unless it's something about, you know, if it's to do with famous people or whatever, yeah, that's fine, go to Wikipedia. But if you're wanting to know something sort of medical or scientific, look and make sure that you're going to an actual sort of university or um, health service or something for the information, rather than just a sponsored site that might be somebody trying to sell you a supplement. Which, when it comes to blood pressure, there really isn't anything on the supplement side that does anything to lower your blood pressure, other than having a healthy lifestyle. Which is probably why quite often you'll have these companies say it'll. Am I back? Am I back, everybody? I knocked something on my computer and I went off. So I'm really sorry. So hopefully I'm back, although I have pretty much finished now. So unless anybody's, yay, I'm back. Unless anybody's got any extra questions, I think I asked everything. Um, if anybody can remember anything that somebody's asked that I've not answered, I think I've gone through pretty much anything. Or if anybody can think of a medication that they think they're on for blood pressure that I've not mentioned. No. So I can't see any questions coming through. And then, yeah, if you, yeah, right. So, yeah, so the risks of working out suddenly with constant low blood pressure. So, when you've got low blood pressure, you've not got as much blood going to your muscles, and so you will struggle. Doing the actual exercise may temporarily increase up your blood pressure, but I would say what you really need to be doing is before you actually get started doing any exercise, is make sure that you're fully hydrated with electrolytes to try and make sure that you've maximised it. Um, I would also say start off slow and steady. Make sure that you do it within your tolerance. And also, I would say make sure you always have a buddy with you, so that if you are feeling faint, you are having any problems, you've got somebody there with you. And if you do feel faint or dizzy, make sure that you go and lay down. So if you're feeling faint and dizzy and there's not enough blood flowing to your brain, the best thing to do is be in the recovery position. So lay on the floor. You don't necessarily have to put yourself in the you could lay on the back, but actually you are best if ever you're feeling dizzy and you think you're going to faint, is actually lay down and put yourself in the recovery position. because then if you end up sort of, sometimes you can end up being sick or whatever. If you're laid on your side in the recovery position, then your airways as open as it can be. But yeah, I would always say, yeah, slow and steady, because in the long run, it will improve your blood pressure. In the long run, it'll increase. But yeah, slow and steady. Can you beat high blood pressure? It can become under control. For the majority of people, you can get the high blood pressure under control. And even if you don't get it fully under control, having just that sort of dropping 10 on the unit. So even if you're always at 160 and you get it down to 150, it might not be in that perfect range, but having that drop will significantly reduce your risk of having stroke and having long-term problems. So even if you can't get it perfect, getting it down a certain amount will actually sort of improve your long-term health. But yeah, it can be very difficult. If you're genetically predisposed to having high blood pressure, you can do, it's good to do all the things on your lifestyle to help it along. But it is no sort of, don't beat yourself up if you can't get it perfect, because sometimes, genetics are just against you, and you just have to do, this is the best that I can do for my body. And yeah, you've got to do it like that. Tastes like, so lick the stream, it tastes like goo medicine. Yeah, there isn't really many medicines that taste very nice. Other than I do quite like the taste of Piriton, sulfonylurea syrup. I think that's the nicest tasting one. It's sort of a minty flavour. Definitely the worst tasting one is Docusate. I have to say, I think that's worse. It's even worse than the penicillin. So a good flesh. What is a good blood pressure? So the top number somewhere between 100 and 140, and bottom figure somewhere between 60 and 80. But really, it depends. So obviously, if you're young and fit and healthy, and it's not causing any problems, then you can have a wider range. If you are diabetic, then we like to have the range sort of be tighter towards the range. So, right. So, oh, did you answer best time to test after medication that has blood pressure spikes? So yeah, so the blood pressure will so if a medication is either going to cause the blood pressure to rise or fall, then it's going to be probably optimum about 2 hours after. It takes about sort of 30 to 60 minutes for it to empty out your stomach into your bloodstream, probably then take another hour to have maximal effect on how its action is. So if you are sort of wanting to test the variations, you can test right before you take the medicine to see what baseline is, then measure it again 2 hours afterwards, and then maybe even measure it sort of 12 hours after to see how long is that medicine still causing an effect, and measure it 12 hours later and see if there's still a difference. So that's what I would do, measure it 2 hours after, 12 hours after, and then just before the next dose. The banana tasting one for strep throat, I think that would be amoxicillin. That's the yellow one. So yeah, I'm not sure it was that banana tasting. It was slightly banana, slightly moldy. So, and then so if there isn't any more questions, thank you all for coming. Make sure that you've liked the stream, subscribe if you'd like to listen to me talk again, and and any ideas for future live streams. I've got my list of videos that I'm going to be doing. So magnesium is my next one. I've got bisphosphonates on the list, mushrooms, vitamin C. So I've got a whole list for actual sort of individual videos, but let me know what sort of subjects you want me to do for live streams. So my next live stream probably be, well, don't know whether it'll be 3 weeks time. Depends when Father's Day is, because when it's Father's Day, I won't be doing a live stream because I'll have to I will be visiting my dad. Yes, I can do cholesterol. I did do a standalone video on cholesterol, but I can do, which was just on should I take a statin, but I could do all the different things regarding cholesterol, because there are some other agents, the fibrates, ezetimibe, and there is now these new biologicals that are being used for treating cholesterol, which is causing major discussions, should I say, in the NHS, because a new one came out that they're trying to get the GPs to do the prescribing of and giving the injections in primary care, which the GPs are already stressed and have too much work to do and fitting in the workload. So there's sort of, well, there again, the consultants also have a big workload. And we're getting more and more of these new agents, these new biologicals, which is great, but it's an ever increasing time pressure and financial pressure. So, yeah, all very interesting. But yeah, I could do cholesterol or anything else if anybody's got any ideas. But thank you all for joining me. It's lovely and sunny still here in the UK. So I'm going to go out and enjoy some time with the rabbits and cats before it gets dark. So see you all. Bye.